Okay, we were just talking about that all this deep structure constitutes a very well-defined block called the central core of the brain, okay? And we see that the internal capsule is within. Remember that internal capsule has 5 parts, and concept, everything that it's above the lentiform nucleus is central, it's a central semiovale or central semiovale, and everything that is in between the superior and inferior part margins of the lentiform nucleus are internal capsule itself, and then they get together and constitute the fibers of the peduncle. Now, if we dissect them from lateral to medial, you're going to be seeing first the lentiform nucleus, okay, and again, everything that is above is central semiovale, okay, and if we remove this, we're going to be seeing the globus pallidus within, and everything that it's inferior to the superior limit of the putamen, this is internal capsule. This is internal capsule, this is globus pallidus, okay? So here we would have the anterior limb, here we would have the genu, here we would have the posterior limb, then the heterolentiform and the sublentiform parts of the capsule. If we remove the capsule, we see that the fibers that are rising from the thalamus. I mean, if we remove the more medial aspects, the more lateral aspects, we're going to see the more medial fibers of the internal capsule, which are the thalamic radiations. Okay, they just arise from the thalamus and go towards the cortex. Again, the internal capsule. And to understand now more what happens to the striatum, let's remember that the striatum, to start with, was a single structure. Throughout evolution, when the mammals came, okay, the corpus callosum developed, and the internal capsule had to develop to become the projection fibers. So we had a splitting of the corpus callosum throughout evolution. Now, since the internal capsule has this fan shape part, okay, what happened? The splitting of the striatum did split the posterior part, the dorsal part, but did not split the anterior part. So you can see here the projection fibers, the internal capsule. You can see this is all striatum, okay? So the dorsal striatum was divided into the caudate and into the putamen, but the ventral striatum was not divided by evolution because this ventral striatum was kept together. And ventral striatum is synonym of nucleus accumbens. So this is the nucleus accumbens. So this is caudate, this is putamen, this is nucleus accumbens. That corresponds again to the ventral striatum area, pretty much synonym of nucleus accumbens. Okay, let's do this dissection of these fibers now from lateral. We see the sulci. We're going to be seeing the sulci next lecture better, the sulci and the gyri. If we remove, we can see the first inter-hemispheric big bundle, which is the superior longitudinal vesicle. We can see here the U fibers that are in between adjacent gyri, and you can see the superior longitudinal fiber, the superior longitudinal vesicle. That has been studied in many ways now, a lot of contributions of cartography as well. But anatomically, we can see very well 3 different components. An horizontal component that goes from the precentral area to the precentral motor area until the supramarginal gyrus, the base of the supramarginal gyrus. Then we can see a vertical area that comes from the base of the supramarginal until the superior and middle temporal lobe gyri. And inside here, you're going to have a continuous vesicle that goes around until that goes from the premotor area until the more anterior in the temporal lobe, which is the arcade vesicle. If we see this in cartography as this beautiful image of Catani here, you can see the horizontal part that is here in green. You can see the vertical part, which is in yellow, and you can see the deeper part that is in red, which is the arcade it's the arcade vesicle itself. So when we come to the longitudinal vesicle, we can see here again 3 components: an horizontal one, a vertical one, and an inner one that is the real arcade vesicle. Now, if we remove the insular surface, we are exposing what is called the extreme capsule. What is the extreme capsule? The extreme capsule is nothing more than the U fibers of the insular gyri. Okay, this is the extreme capsule. And we can see a little bit of dark gray matter because the claustrum is very difficult to dissect sagittally in this type of dissection. If you do an axial cut, you can see better the claustrum, not here. But if we remove this, we're going to exposing now the external capsule, and again you can see a little bit of gray matter of the claustrum. Again, the external capsule is the external capsule of the putamen, of the lentiform nucleus that is right here. We're going to be seeing that we have very well-defined tracts anteriorly, which is the uncinate and the IFOF. I'll be coming back to this shortly. And all the posterior fibers are claustrofugal fibers, fibers that are coming out of the claustrum and are going towards the cortex. If we remove this posterior part of the external capsule, we can see better. We can already see the putamen because we did remove the external capsule of the putamen, okay? And we can see what we remove here was the claustrofugal fibers. But we can see that anteriorly, the external capsule has pretty much two very well-defined tracts. An anterior one, which is the uncinate, that is putting together the orbital part of the frontal lobe with the anterior and mesial parts of the temporal lobe. And we can see another bunch of fibers that comes from here, the base of the opercular area, frontal opercular area, that goes posteriorly, which is the inferior frontal occipital fascicle, also called occipital frontal fascicle. This fascicle is being very popular now among neurosurgeons with all these courses of fiber dissections. And it made popular by Hugues Dufault, that doing awake surgery believes that the IFOF is related to semantic aspects of the language, while the arcuate that I just mentioned to you is more related with phonological aspects of language. But you can see very well here that in this part you have the IFOF coming here, and you have the uncinate fascicle coming here. In this slide, we did cut already the superior longitudinal fascicle, and you can see that you have lots of fibers all together here that are covering the inferior horn and the atrium laterally here. All these fibers together, we're going to see them more closely now, they are all together referred to as being the sagittal stratum. This was a name that became very popular by Klinger. Klinger was the one that made popular the white matter dissection using this frozen brains technique, and so this term, this concept, belong very, very well known. The sagittal stratum again, which are all the fibers that are covering the inferior horn and the atrium as well. And of course, they include the IFOF, and more anterior, they include a little bit of the uncinate fibers as well, and they lie just underneath this vertical part of the sagittal stratum, of the superior longitudinal fascicle. In this slide now, what did we remove? We did remove the striatum. We're going to be coming back to the sagittal stratum shortly. We did remove the lentiform, the putamen. Having removed the lentiform, the putamen of the lentiform, we can see the globus pallidus, and we can see internal capsule fibers. Let's see a little bit this very interesting region and understand some other concepts here. Anatomy, it's a lot of concepts. So when we talk internal capsule, it's a concept. When you talk sagittal stratum, it's another concept. When you talk temporal stem, another concept. And some fibers belong both to the internal capsule and to the sagittal stratum, as we're going to be seeing. So we have to understand not only the concepts, but we have to understand where these structures are. That's my aim here, is to show where these structures are. So again, we are seeing a very well-defined region here that has been very studied recently by Heimer and other neuroanatomists, and it's very popular now with this surgery of insular gliomas and of course of epilepsy as well. What are we seeing here? We're seeing the globus pallidus, we're seeing the internal capsule, we're seeing the anterior commissure just running underneath the globus pallidus, we're seeing the IFOF, inferior frontal orbital fascicle, related with semantic aspects of language according to Dufault, and we've seen very well the uncinate. Okay? We see in the anterior perforate substance here, where the lenticular-striate arteries are coming in. Okay, this area in the past was called as the substantia nominata. Why this name? Because they didn't know exactly where it was there. Now, substantia nominata nowadays is understood mostly as the most anterior part of the globus pallidus, the ventral pallidus. Here you're seeing the accumbens, the ventral striatum. So this area is being called by Heimer at the ventral striatum pallido region. And this area has as its roof the internal capsule, the anterior limb of the internal capsule, as its medial aspect, the accumbens itself, and as its anterior wall and floor, the anterior perforate substance itself, and posterior wall, the anterior commissure. This area is continuously laterally with another concept, the concept of temporal stem. Okay? Temporal stem, for some, are just all the fibers that are running along the inferior limiting sulcus of the insula. For others, as I believe, just this anterior part that I'm going to be showing a little bit later, which is the IFOF, the uncinate vesicle, and the upper extension of the amygdala down there. But anyway, what is important to understand in terms of the architecture of the brain is that all the fibers of the sagittal stratum here are going to be anteriorly continuous with the temporal stem. And the temporal stem is continuous with this region that I'm calling ventral striatum. And this region is continuous medially with the septal region. So this all together constitute, let me say again, the temporal stem, the substantia nominata region that it's also called ventral striatum region, and from some neurosurgeons is also called anterior perforate substance region. Okay? Why this? Because this is, when we talk about anterior perforate substance itself, is the anterior wall where the lenticular-striate arteries are coming through. But some authors are calling this anterior perforate substance region, which is also a good name for this region. And this is important because insular tumor comes from the temporal stem and gets into this region, and they go more medially and go to the septal region. Now, what is the basal forebrain concept? The basal forebrain concept is a very broad concept, older concept, that puts together the temporal stem, this ventral striatum region, and the septal region. All this is all together is the basal and ventral aspect of the brain that is called basal forebrain region. So important for us to understand all these concepts. You see here the lenticular-striate arteries coming through the anterior perforate substance and getting inside this region. Let's call anterior perforate substance region. I think it's a good name, it's a more neurosurgical name. And here you can see, again, the sagittal stratum with all the fibers that are covering the ventricle. Down here you're seeing the head of the hippocampus. Okay, if I remove now, let me come back here. Next dissection, I'll be removing the more superficial fibers of the sagittal stratum, namely the IFOF, fibers. If I remove this, you're going to be seeing that the layer that comes just next is the layers of the anterior commissure. You see here the anterior commissure running underneath the globus pallidus, and then opening. You have anterior commissure fibers that go anteriorly, and they also go posteriorly, running just underneath the globus pallidus. Now, I can detach the anterior commissure from the channel of Gratiolet that you're going to be seeing next. And of course, here's the amygdala. This is ansa peduncularis. And now I'm going to be cutting here the anterior commissure, and I'm going to be removing the anterior commissure fibers that are going posteriorly, just like I did here. And I see that I have another group of fibers. This other group of fibers are the optic radiation fibers that are coming from the lateral geniculate body region, as I'm going to be showing later, go anterior as the Meyer loop, and go posterior as the optic radiation fibers. Here are the anterior commissure fibers that were left. This is globus pallidus, this is amygdala. This is the caudate, and this is the accumbens. ventral striatum. Ventral striatum and accumbens are the same thing. So you can see here that the ventral striatum is the medial part of the region that I'm talking about here, that some call anterior peripheral substance region. This is optic radiation. Let me just come back here to you. So if we come back here, we've seen the IFOF, we've seen the uncinate, and now we know that the IFOF is the more superficial layer of the sagittal stratum. Sagittal stratum is covering the inferior horn and the atrium. Underneath the IFOF, I'll have the anterior commissure fibers. And underneath the anterior commissure fibers, I'll have the optic radiation coming here. All these belong to the concept of sagittal stratum. They do not belong to the concept of temporal stem. Temporal stem is IFOF, is uncinate, is the upper extension of the amygdala. And remember that this temporal stem that will be here, for some will include these fibers here, not for me, just as anterior fibers. This temporal stem is continuous along the ventral striatum region, or anterior peripheral substance region that will be continually medially with the septal region. And all this together constitute the basal forebrain. If you go look for the definition of basal forebrain, you're going to read that includes only the ventral aspect of the globus pallidus and the ventral striatum. That's the posterior aspect of the basal forebrain when you're going to read about its definition. For us neurosurgeons, it's important to understand the architecture of this region, particularly because insular tumors will get also here. Now, if I detach the anterior commissure from this channel, I can see this very well-defined groove, which is the channel graciole. And again, remember that the amygdala, that is just anterior to the head of hippocampus, is continuous superior with the globus pallidus. We're talking all about this very interesting region, which is a limbic region. Inside this region, you have the minor nucleus, the nucleus basalis of minor. This is all a cholinergic area, is the most important cholinergic area output for the brain. Very important in dementias, in Alzheimer's, and other neuropsychiatric diseases, as you know. Accumbens is its medial aspect. And more medially, this is continuous with the septal region inside there, as we're going to be seeing later. Okay, let's see what is underneath here now. Again, this is an interesting dissection because here we have the basal forebrain, the base. You see the anterior perforated substance. This is not dissected, and this is dissected. You have here the accumbens. You see that the accumbens, it's very much deep to the rectus gyrus. It's inside the rectus gyrus. And you have here the anterior commissure. This is anterior commissure. This is globus pallidus, this is channel graciole. And this is amygdala. And this is ansa peduncularis. Ansa peduncularis is the output of the amygdala. And ansa peduncularis has three components. One component, the most superficial one, goes to the septal region, which is here. Then you have the component that goes to hypothalamus, and another component that goes to the thalamus. Septal region, thalamus, hypothalamus, all together ansa peduncularis. Now, the more superficial fibers, this output of the amygdalofugal fibers, are the fibers that are going to the septum, to the septal area. They are so superficial that in the non-dissected part of the brain, you can see that they constitute a ridge. This ridge here is the so-called diagonal band of Broca. So the diagonal band of Broca is this ridge that is within the anterior peripheral substance itself, which is the wall of the region that we're talking about. The anterior commissure is the posterior part of this region we're talking about. And you can see that the most superficial fibers of the ansa peduncularis, they are going towards the septal region here in the midline. Next lecture about suicide gyri, we're going to be seeing better this septal region. So this is accumbens. This is the septal region. We're going to be seeing next lecture, this is the cingulate, and this is rectus gyrus. Rectus gyrus superior, it has the superior rostral sulcus. And inside the rectus gyrus, you have the inferior rostral sulcus. When a sulcus ends, you have a connection. This beautiful U here is called cingulate pole by Asagio. And posterior to the cingulate pole, you have three very small gyri. One that is just anterior to the anterior commissure, which is the paraterminal gyrus. Then you have posterior parofactory and anterior parofactory. The real septal area is within the paraterminal gyrus. Here you have the septal nuclei, which are important because they are the gates to the hypothalamus. All cortical information that goes to the hypothalamus goes to the septal region. So this is also called real septum, because this is false septum. The septum pellucidum is the false septum. The septal region is the real septum, where you have the septal nuclei. This is also called paraolfactory area of Broca. Paraolfactory area of Broca. And this is the most inner aspect of the basal forebrain. Basal forebrain inside here will be continuous with the ventral striatum region, also called substantia nominata, also called anterior peripheral substance region, that laterally will be continuous with the temporal stem, that posterior will be continuous with the sagittal stratum. Different concepts. Let's see this beautiful dissection now done by Richard, and we're going to be seeing other very interesting things. This is the anterior commissure. Theodore Meinert was a very important neuroanatomist, psychiatrist, and neurologist of the 19th century. And he was the one that described the commissural association fibers, commissural fibers, projection fibers. He gave this name. But he studied very much the anterior commissure, and he came to this definition that the anterior commissure has two parts: the hemispheric part, which is this big part that you always think about, and a very small part that is the olfactory part of the anterior commissure, showing that the anterior commissure is a very, very old commissural system. It was very, very, very important in reptiles because they put together both olfactory systems. The very ancient reptiles, they did not have neocortex, they don't have corpus callosum. So that's what the anterior commissure was their corpus callosum. When the mammals came, all these telencephalic structures developed, and the anterior commissure sort of lost a lot of function. But it was very, very important. And what is interesting in neuroanatomy is that all these vestigial structures were left there by evolution. They were just left there. So of course, this has no more function, but it has very many more function in the very old reptiles. It's very interesting that the optic nerve has pretty much almost the same diameter as the anterior commissure. And optic nerve is our main cranial nerve. We are visual animals. Both optical nerves, they constitute 40% of all the fibers of all the cranial nerves put together. So optic nerve has 1 million fibers. The anterior commissure has 3.6 million fibers, 3 times more than the optic nerve, showing how important this was in the past in evolution, but it was just left there. And this olfactory part that put together what they used to call rhinencephalon area of the reptiles show that this was very important to put both the olfactory system all together. And I never had seen a beautiful dissection, as Richard showed here, of this olfactory part of the anterior commissure. Now, posterior here, of course, you see in the fornix. This is the pillar of the fornix. Most of the pillar of the fornix goes posterior to the anterior commissure towards the mammillary body. But there's also a precommissural part of the fornix that comes anterior, and where does it go to? It comes here. It comes to the septal region. So you see the septum here, you see the fornix. Most of the fornix is post-commissural form. This is anterior commissure. Post-commissural fibers that goes to the mammillary body down here. But there is a component of the fornix that is pre-commissural that will end in the septal region. This pre-commissural part will end in the septal region that was removed here. So this is a very interesting part, again, to show this very basal forebrain area, very, very interesting and difficult to understand. Okay. So let's put together layers we've been talking about: the insula, cortex, the extreme capsule together with the claustrum, which are U fibers of the insula, subcortical white matter of the insula. Then you have the external capsule of the putamen. This is already putamen. The posterior part are claustrofugal fibers, and anterior you have the IFOF, and you have the uncinate vesicle that will be coming here. Of course, here, this is what was left of the superior longitudinal vesicle. You have here corona radiata or centrosemiovale. Some of these fibers are getting inside the striatum, are the cortical striatum fibers. They do not belong to the concept of internal capsule because they don't go inferior to the inferior margin of the putamen. They just get inside. They don't go towards the peduncle. They just get inside the striatum, the putamen, namely here. Posterior here, we see the sagittal stratum that I've been talking about. Sagittal stratum, what do we have here? We have the IFOF, we have anterior commissure fibers, and you have optic radiation down there. Now, if we do a window here in the sagittal stratum, you see how deep the sagittal stratum is? IFOF, anterior commissure, optic radiation. You can see fibers that have another orientation, another direction. These fibers, they are running exactly underneath the optic radiation. They are called the tapetum. And the tapetum arises at the posterior part of the corpus callosum, at the splenium. You see these beautiful fibers here coming out of the splenium? They constitute the tapetum. If you go to old Gray's Anatomy definition of tapetum, it's written, tapetum are the fibers that are running underneath the optic radiation. They are in between the optic radiation and the ependyma of the lateral ventricle. And you know what tapetum means? In Latin means carpet. So the tapetum is the carpet of the optic radiation. Tapetum is coming here. This is tapetum. It's arising here. The tapetum fibers do not belong to the concept of sagittal stratum. Okay. We're talking about these fibers trying to show their architecture in relation to the ventricle, because we neurosurgeons have to understand this in relation to the ventricle. It's easier. When you see an MRI, you start seeing the sulci, you see the ventricles. And from the shape of the ventricles, you're going to identify the deep structures. That's how you should do. So you should understand the structures from the ventricles. Like Dr. Rotten said, what is the roof? What is the anterior wall? What is the floor? So let's see from the base now. I'm going to emphasize next lecture that a gyrus is a concept also. Here you have a very well-defined fusiform gyrus. Collateral sulcus, occipitotemporal sulcus. Fusiform. Here you see the tip of the fusiform. I would say this is the region of the fusiform gyrus. Fusiform gyrus is not a very well-defined region. It's a concept. Sometimes it's very well-defined, sometimes not. We're going to be coming back to this. But in terms of architecture, what I want to emphasize is that the fusiform gyrus is the floor of the ventricle. The fusiform gyrus is the floor of the ventricle. We're going to be seeing tomorrow, when I show some surgeries, that the anterior half is the floor of the inferior horn. The posterior half is the floor of the atrium. So now let's dissect what we have in between the surface of the fusiform and the ventricular cavity, and from there we go to the roof. If we remove inferior diffusiform gyrus, we're going to be seeing that there is a very well-defined tract inside it, which is the inferior longitudinal vesicle. Inferior longitudinal vesicle. Very important for face recognition and a lot of other functions. I'm not talking about this here. But this is inferior longitudinal inferior longitudinal vesicle. If I remove this, I'll get in the ventricular cavity. And if I go towards the roof, this is the roof of the inferior horn. What can I see here? Let's see. Optic tract, peduncle, substantia nigra, tegmental area of the part of the midbrain, aqueduct. What sulcus is this? Already said, between the peduncle and the midbrain, tegmental. Lateral mesencephalic sulcus. At the top of the lateral mesencephalic sulcus, I will always have the medial geniculate body. Always there, very round, very prominent, very well defined. More lateral and more anterior, I have the lateral geniculate body, where the optic tract ends. And from this region, you have the optic radiation. This is all optic radiation. This is the Meyer loop. This is optic radiation. And in this beautiful dissection, you can see that the optic radiation fibers, they don't arise only from the lateral geniculate body. They arise from the posterior part of the thalamus, from the pulvinar. And if you go to very old neuroanatomy books, you see that old neuroanatomists, they used to call this posterior part of the thalamus the optic thalamus. Optic thalamus. Because from this part of the thalamus arise the optic radiation. By the way, optic radiation was described by Gratiolet, who maybe was one of the most important neuroanatomists. He described the optic radiation among other things I'll show later. So this is optic radiation. This is in the roof. To see this, I did remove the ependyma. And here I'm in the roof of the inferior horn. This is anterior commissure. You see that the fibers of the anterior commissure are superiorly to the optic radiation. This is all sagittal stratum concept. Next slide, I'm going to be removing the optic radiation fibers. Tapetum doesn't get to here. Tapetum just takes the posterior part of the optic radiation. This is more anterior temporal. I'm going to remove the optic radiation. If I remove the optic radiation, let's see where we are again. Optic tract, lateral geniculate body, roof of the inferior horn. Let me tell you that this is amygdala. What is this dorsal extension of the amygdala? What is this? Stria terminalis. The head of hippocampus would be here. Remember that the amygdala is anterior to the head of hippocampus and covers a little bit the head of hippocampus. So this is amygdala. If I go more superior, I'll be going towards the globus pallidus, because the amygdala is superiorly continuous with the globus pallidus. Okay? Now, what is this thing here? Try to think about everything that I said until now. What is this? Exactly. This is the tail of the caudate. You see the tail of the caudate that it's running in the roof of the inferior horn, and as I already showed, it's going to merge with the amygdala. So this is superior to the roof of the inferior horn. Again, the caudate. This is the head of the caudate. This is the body of the caudate. This is the tail of the caudate that will merge with the amygdala within the roof, superior to the roof of the inferior horn. Very nice dissection. And again, to show that the amygdala goes towards the globus pallidus. And now you can understand better this dissection. This is globus pallidus. This is internal capsule fibers. This is optic radiation. Okay? This is accumbens, ventral striatum. This is the head of the caudate. This is the region I've been talking about I like to use the term ventral striatum region because Heimer used to use this name. This is optic radiation. What do I have superior here over optic? I have anterior commissure fibers, and then I will have the IFOF over all this. Let's come back to the uncus. Let's emphasize that the anterior half is the amygdala, posterior half is the head of the hippocampus. Let's now understand better what I showed in the beginning. This is the base of the putamen. This is globus pallidus. This is where the amygdala will go superior here. Of course, this is hippocampus. To expose this, I did remove the head of hippocampus that was here. Peduncle, posterior perforated substance, mammillary bodies, anterior mammillary bodies. This is hypothalamus. Let's understand better this now. This is the amygdala that superiorly goes towards the lateral aspect of the basal forebrain, namely to the globus pallidus. That's why the choroidal fissure starts posterior here, because the amygdala will be covering here. So the inferior choroidal fissure will be starting in the inferior choroidal point and will end at the foramen Monroe. So this is choroidal fissure open, and I have this big stem here, where this is the head of hippocampus, this is amygdala. Inside here I'll have the upper extension of the amygdala, and here I will be coming the uncinate, the IFOF. This is what we call temporal stem. For others, all the fibers that come here would be also temporal stem. You see the temporal stem here? And this is the pulvinar that is resting in the subiculum. This is a natural space. Okay, let me end this lecture doing a coronal dissection, ending with the third ventricle. Let's remove the opercular part. If we remove, this is the opercular part of the inferior frontal gyrus. We'll get this next lecture. This is the anterior wall, the anterior face of the insula. The insula has a lateral aspect and an anterior aspect. This is anterior limb of the capsule. This is the head of the caudate, bulging as the lateral wall of the anterior horn. If I remove this, I can see insula here. I can see extreme capsule. I can see the claustrum. I can see the external capsule. And I can see the striatum together. The anterior limb of the capsule in this specimen was not very much developed, because this is caudate. What bulges in the ventricle is caudate. What is lateral is putamen. Anterior limb is not very well developed. This is rostrum of callosum. This is trunk of callosum. If I go more posterior, I start to see the anterior commissure. Anterior commissure. Again, I'm going to repeat for you all to understand. Septal region, cingulate pole, anterior commissure. This is the posterior limit of this region, that it's the ventral striatum or anterior perforated substance, that immediately is continued with the septal region of this side, and laterally is continued with the so-called temporal stem. Cut the anterior commissure, I see the fornix will end mostly at the mammillary body. Everything that is anterior to the mammillary body is floor of the hypothalamic part of the floor of the third ventricle. And here you can see that the posterior part of the roof, of the floor of the third ventricle, posterior part, is the roof of the interpeduncular fossa that is in between two peduncles. Anterior commissure, fornix, septal region. Foramen Monroe, so I'm at the level of the genu of the capsule. Genu of the capsule is just next to foramen Monroe. So this is posterior limb. Just posterior limb is related with the thalamus that is here and with the third ventricle. So if I remove the thalamus and the posterior limb of the capsule that was over the thalamus, okay, I can see the third ventricle. Let's understand a little bit better to finish this lecture, the third ventricle. Anterior commissure, pillar of the fornix, will get inside here, it will end in the mammillary bodies. Everything anterior to the mammillary body is the hypothalamic floor of the third ventricle. This is the pituitary stalk. This is mammillary body. This is optic chiasm. This is all hypothalamic part of the floor of the third ventricle. This is the floor of the third ventricle that's within the midbrain already. Aqueduct is here. You see the hypothalamic sulcus comes from the foramen moral towards the opening of the aqueduct. Everything here is hypothalamus. Everything superior to the sulcus is thalamus. This is massa intermedia that was cut here. Let's see the roof. Here I can see very well the fornix, and I can see the medulla stria of the thalamus. Medulla stria of the thalamus. Medulla stria of the thalamus ends at the abenular nuclei. Abenular nuclei are just posterior here in the thalamus. It brings limbic information towards the abenula. This limbic information comes from the fornix, comes from the basal forebrain bundle that I didn't talk about, comes from all this area around the foramen Monroe, and comes also from the stria terminalis. I also keep thinking myself, these are all vestigial structures. I don't believe they have any function. Maybe they have some fine-tuning function, I don't know, but that's what you read in the books. And they go to the abenula along the stria medullaris of the thalami, and from the abenula they will project into interpeduncular nucleus of the midbrain. We'll show this later. But architecture, what is important is that there is a space in between the fornix and the medullary stria of the thalamus here. And in between, you have this space. Within this space, you have the internal cerebral veins, and you have the posteromedial choroidal arteries. This space here is the velum interpositum. Velum interpositum is a cistern that is continuous with the cistern of the pineal region. Here's the pineal. Here's the pineal. Pineal cistern continues with the velum interpositum. And this is all within the roof of the third ventricle. So the upper part is the fornix, the lower part medullary tree of the thalamus, and then you have here the velum interpositum cistern with the internal cerebral veins and with the posteromedial choroidal arteries. Of course, this ends in the foramen Monroe. Here you have the pillar of the fornix going posterior to the anterior commissure, post-commissural fibers of the fornix going towards the mammillary body. And you remember that you have a precommissural fibers that are not shown here that will end in the septal region here. Septal region is right here. If we remove this wall, we can see these interesting structures within the wall of the third ventricle. Beautiful dissection done by Richard. Mammillary body. Here you have the pillar of the fornix getting to the mammillary body. I'm sorry, you have the fornix here. This is the pillar of the fornix getting to the mammillary body. This is the mammillothalamic tract of Rectus Gyrus, that belongs to the circuit of Papez. Inferior to the thalamus, you have the subthalamic nucleus of Louis. This is already the red nucleus here. This is all red nucleus. And this is the fiber system that I told that comes from the abenula towards the interpeduncular nucleus here. Has a name, fasciculus retroflexus of Minor also. But it's the habenulo-interpeduncular tract. Very difficult to dissect. It goes in this groove within the red nucleus. And of course, this is third nerve fibers arising in the interpeduncular fossa. This is the pineal. Let's understand the pineal. Remember, this is the abenula. This is the abenula. This is posterior commissure. Sorry, I forgot to mention that the posterior commissure is the inferior margin of the aqueduct. I'll be coming back to them. I'm going to show you some endoscopic surgery here to finish. But let's understand the pineal. I have an abenula one side, abenula the other side. In between both abenula, I have the commissure of the abenulus. And then I have the posterior commissure down here. Posterior commissure, it's the superior aspect of the aqueduct. In between the abenular commissure and the posterior commissure, I have the pineal recess. And the pineal has two arms. The upper arm is grabbing the abenular commissure, and the inferior arm is grabbing the posterior commissure. And in between, you have the pineal recess. Superior to it, superior to the abenula, you have the suprapineal recess. When you go with the endoscope, you have to see this. So here we are with the endoscope. This is posterior. This is anterior. This is the chiasm. You have to start seeing what is easy to see, mammillary bodies and chiasm. This is suprachiasmatic recess. This is infundibular recess. Mammillary bodies. Everything here is hypothalamus. Everything posterior is midbrain. The aqueduct. Here, this is the commissure of the abenula. I'm sorry, this is the posterior commissure. Posterior commissure is the upper aspect of the aqueduct. Posterior commissure is the upper aspect of the aqueduct. This is all midbrain, which is the posterior part of the floor of the third ventricle. This area just anterior to the mammillary bodies that sometimes is very reddish when you go to endoscope here, is called tuber cinereum. Tuber cinereum area. That's where it's, when you have the thinner floor of the third ventricle is where you do your third ventriculostomy. Always anterior to the mammillary body, otherwise we'll get inside midbrain. Of course, here you're going to get into the basilar tip and prepontine cistern down there. The tuber cinereum is important because in the tuber cinereum you have the neurons, which axons will go to the pituitary, to the infundibular. The tuber cinereum is continuous with this all lateral aspect of the infundibulum, which is called median eminence. So median eminence are the ridge that you have around the infundibulum. Median eminence continues with the tuber cinereum until the mammillary bodies area. Posterior midbrain. Then you have aqueduct, superior margin of the aqueduct, posterior commissure. Now, if you go posterior, you see in the aqueduct. What is this again? This is posterior commissure. And what is this? This is the abenular commissure. This is abenular one side, abenular other side. So this is pineal recess. The upper arm of pineal is grabbing here. The inferior arm of pineal is grabbing here. So this is pineal recess. And superior to it, you have the suprapineal recess of the third ventricle. So you have to know this architecture. You have to have, and you have to know in order to identify. The more you know, the more you see. And this is just to show this beautiful dissection. We work with Aldo Stam, which is an ENT guy that it's superb with endoscope. And together we've been able to remove this endonasal transsphenoidal. This is a mass intermediate. This is the view of the third ventricle after the removal of this tumor. You can see here both foramen Monroe. And the more you know, the more you see. You have to know that anterior margin of foramen Monroe is fornix. This is fornix. This is fornix. Posterior margin of foramen Monroe is the anterior thalamus. The anterior, you have 3 anterior tubercles of the thalamus here, and all the anterior thalamic nucleus are around in this area. All of them are here. If you put your bipolar here, you're going to damage the all anterior thalamic nuclei in this side. And here's the massa intermedia or interthalamic adhesion. This is the roof. You see the roof down there, choroid plexus within the roof of the third ventricle, as you know. If you get to the ventricle, you look for the striothalamic vein. If the striothalamic vein is lateral to your approach, it's because you're approaching the lateral ventricle, the side you're going to. Septal vein, striothalamic vein. Nowadays, you know that underneath the striothalamic vein, you have the stria terminalis. This is fornix. Fornix is continuous with the rostrum callosum, no separation. If I have time, I'll show you some surgery of ventricles. Fornix, pillar of the fornix, continues with the rostrum callosum. Now, let's understand relationships of the lateral ventricle with the third ventricle. This is choroidal fissure. If I open choroidal fissure anteriorly, I'm getting into the third ventricle. Now, if I open choroidal underneath the body of the fornix, now if I open choroidal fissure underneath the crude of the fornix, I'll get inside the pineal region. If I open here, I'm going to get here. You have to have this architecture in mind. Let me just come back here and tell you why I emphasize the levels of this building. Remember that the anterior horn is at the same level of the body of the ventricle. I'm sorry, anterior horn is the same level at the third ventricle. It's the same level of the atrium. The body of the ventricle is in a level above. Next lecture, we're going to be talking about the insula, and we have to have an X-ray vision of these structures that are underneath the insula. So again, if I open here, third ventricle, underneath the body of the fornix. If I open underneath the crude of the fornix, I'll get into the pineal system. I'll get right here. And really to end, I'm talking about concepts because I think the concepts help us to understand the architecture. Yasagil tells us that we have three important fissures. Two fissures are very important, very easy to understand. One is the interhemispheric fissure. The other is the Sylvan fissure. And the third one is the transverse fissure, was described by a French called Bichat. Transverse fissure of Bichat. What is the transverse fissure of Bichat? Transverse fissure of Bichat is the crural cistern, the ambient cistern, and then the pineal cistern, and the velum interpositum cistern. Why I'm showing this? Because I talked about, of course you have the thalamus here. If you understand these fissures, you understand the whole anatomy of the deep structures of the brain. The ambient cistern will be between the medial aspect of the temporal lobe and the peduncle. And it will ascend here. Ambient fissure, the ambient cistern will end in the pineal cistern. And the pineal cistern goes anteriorly within the roof of the third ventricle as the velum interpositum cistern. And just to do an advertisement of the book we just did, just came to the Cambridge Press, and it's everything there. What I try to teach here is there, and including the cases I used to show you. Well, that's what I want to show this morning, and if there's any question, please, or any doubts or any suggestions.